Hello, good evening, everyone. Namaste, Jai Shri Krishna. My name is Dr. Neel Thakkar. I am from Vadodara, Gujarat. Today, Chest Council of India has again come with a very interesting topic just before the occasion of World No Tobacco Day. On the CCI COPD webinar series, part 6. The topic for discussion today is Breathe Again, Bridging Smoking Cessation and Pulmonary Rehabilitation for Lung Revival in COPD Patients. So today we have a very interesting panel with us. And again, thank you, Chest Council of India, for taking these webinars through so many years, finding unique topics as well as a very interesting group of senior academic professionals and experts to discuss and regarding these topics. So, with the occasion of World No Tobacco Day coming in a couple of days, we need to know that the theme this year is unmasking the appeal and exposing the industry tactics on tobacco and nicotine products. So while we will be discussing regarding this also in our panel, it is very important to address that in majority of chronic respiratory disorders, be it COPD, be it interstitial lung disease, be it lung cancer, be it majority of any chronic respiratory as well as a lot of cardiac illness also, we find smoking as a very severe addiction which continues despite taking all the maximum therapy. And a lot of times, as consultants, as specialists, as physicians, we do not address this in giving it sufficient time in our clinics. So, today we'll be discussing regarding smoking cessation and pulmonary rehab. I have a very esteemed panel with me today from all various parts of the country as well as various specialities. We have with us Dr. Battu Chaithanya. She is MBBS, DTCD, DNB Respiratory Medicine, a medical lead and in lung transplantation from Apollo Hospitals, Hyderabad, with us today. We also have Dr. Arnab Bera. He is MD, DNB Respiratory Medicine, FNB Critical Care, working as a consultant respiratory medicine in Manipal Hospital, Salt Lake in Kolkatta. Sir is a DNB teacher and a faculty in various state and national conferences with special interest in critical care and interventional pulmonology. We also have with us Dr. D C Gupta, sir. He is a HOD senior consultant and interventional pulmonologist, Department of Pulmonary Medicine at Mangalam Plus Medispeciality Hospital in Jaipur. Sir is a very senior professional with many numerous international, national conferences where he's been as a speaker. He is also believes that we should do something for humanity. He was an integral part of the Special Olympics Bharat and represented our country there in Philippines, in also in Berlin, Germany, and recently visited Indonesia as the part of the Indian delegation in the Asia Pacific Olympics. So we are grateful that we have Sir with us to discuss on this topic. We also have Dr. Vrushali with us. She is currently affiliated with Shwas Clinic, Pune Hospital and Research Center in Pune, and is a senior consultant physician and is amongst her various academic achievements. She has numerous national as well as international publications and awarded as a trailblazer in pulmonary medicine in NAPCON. And she also has many national as well as international publications to her name. So I would not waste more time and get into the academic discussion. First, we have a talk by Dr. D C Gupta, who will be giving his insights regarding pulmonary rehabilitation, and followed by a talk by Dr. Arnab Bera on smoking cessation, followed by a very interesting panel discussion. So I will hand over to Dr. D C Gupta to share his views regarding pulmonary rehabilitation. Thank you.
It's very nice to meet you all on the platform of the CCI. Today we are discussing about the pulmonary rehabilitation. It's very essential in the patients with the COPD, patients who are smoking, and malnourished patients. So the pulmonary rehabilitation have an essential role in our COPD patients, asthma patients, and debilitated patients. So What is the definition of pulmonary rehabilitation? It's a multidisciplinary services directed to person with pulmonary disease and their families, usually by a team of specialists with the goal of achieving and maintaining the individual maximum level of independence and functioning in the community. So, the pulmonary rehabilitation at least should be considered for the patient with the COPD who have dyspnea, respiratory symptoms, exercise intolerance, or restrictions in the activity or impaired health status. So, what are the benefits? Pulmonary rehabilitation improved exercise capacity, reduced perceived intensity of the dyspnea, quality of life, reduce hospitalization. It also reduce anxiety and depression from the COPD, improve limb functions, and benefits extended beyond immediate period of the training. What should be our goal? Our goal for the rehabilitation to reduce the symptoms, decrease disability, increase participation in physical and social activities, improve quality of life and long-term benefits, and some health economic advantage. So, what should be the selection criteria of the patients? The patients may be of obstructive disease, restrictive disease, or other disease, COPD, bronchiectasis, cystic fibrosis, or ILD, chest wall disease, neuromuscular disease, even the lung carcinoma, post-surgical patients, patients who have obesity, pulmonary hypertension. So what is the criteria to choose patients for the pulmonary rehab? Confirmed by the spirometry, breathlessness score more than 3, FEV1 less than 50%, and motivated for this 10-week program. At least there is a no contraindication. These are the, so how we set for the pulmonary rehabilitation. There may be outpatients, OPD patients, IPD patients, as well as home care patients. The team include the doctors, nurses, dietitians, physiotherapists, occupational therapists, respiratory therapists, psychiatrists, and social workers, along with the family members. So, there is a patient and family education, pharmacological treatment, non-pharmacological treatment, muscle training, respiratory muscle training, breathing exercises, pursed breathing, cough and huff, postal drainage. So, we took one by one all these things. There should be also focus on the nutrition, psychosocial behavior, vocational rehabilitation, and sexual rehabilitation is also important. So first of all, the educational component, the anatomy, we should know about the anatomy of the lungs, airway, energy conservation, oxygen therapy, respiratory, symptom management, and end of the life, as well as smoking cessation. As we know, in the next coming days, on the 31st, there is a no smoking day. So also smoking cessation is very important part. Also, as well as how these patients can travel, and almost, and also there is a nutrition. As you know, there is a no cure for the COPD patients. So how we improve the quality of the life? How to live with the cope with the COPD? Because the safety inside the bathroom, showers, all courts, non-sleepers, all should be used in our home. And conservation of energy is very, very important. To conserve this, there is a controlled breathing, and avoid unnecessary activities. Also, to organize these organized activities, closet, shelves, and maintain good posture, and try to relax. So now come to the pharmacological and the non-pharmacological interventions. Nursing interventions, as you know, patients are hypoxemic. COPD patients who smoke are hypoxemic. There is a requirement of the oxygen. Remember, oxygen is a drug. So be cautious using the oxygen because there are so many dangerous side effects also. There is oxygen toxicity, CO2 retention, atelectasis, and so many things. So medications, proper medications, proper inhalation techniques, and appropriate use of the oxygen is of utmost importance. And you must, you must stop smoking because it is very, very dangerous for the patients, especially with the obstructive airway disease as well as other lung disease, especially very dangerous. And also it harmful for all over our body. There are so many carcinogenic chemicals in this. So we must stop smoking. There are 5A rule for the smoking cessation. Ask, advise, assess, assist, and arrange. These are the 5 key rules how we can start smoking cessation. So, clinician and healthcare delivery system must institutionalize the consistent identification, documentation, and counseling of the every tobacco user at every visit. Now, come to the physical muscle training. Aerobic exercises, 6 weeks to 3 months to achieve significant improvement. It includes walking, biking, swimming, water aerobics, low impact aerobics. So before starting exercise, we must use fast acting inhalers. So there is a less chances of the hypoxemia and the fatigue. And if requirement, we should use oxygen. It will improve quality of life, improving mood, improving sleep. Respiratory muscle training is also important with the exercise. So target endurance training of 20 to 30 minutes, repeated 2 to 5 a week. Chest physical therapy. How to do? There is a through the pursed lip breathing, through the postural technique, diaphragmatic breathing, and the postural training. So now, pursed lip increases the resistance to outflow of air. So it prevents airway collapse by increasing pressure. So pursed lip is very, very useful in patients with the type 2 respiratory failure who retains CO2. Postural drainage. Postural drainage is very useful. Some patients who are having bronchiectasis, the spill out of cough and the sputum is very useful. Postural drainage is very, very useful. Huff. It's a maneuver. It's a maneuver to expel out. Expel out through the open glottis. Is produced by the huffing can be manipulated by varying the lung volume at which the huff is commenced. So with the lobar and the segmental bronchi, low volume in the peripheral airways. Now come to the psychological rehabilitation. To relieve anxiety, depression, difficulty coping with the chronic disease, relaxation techniques. Now come to the nutritional. Nutrition is very, very important because if there is a no adequate calorie intake, so there may be a trouble with all these therapies because energy is very, very energy requirement for these rehabilitation program. Malnourished patients, so there is a If BMI is less than 20, there is an increased overall mortality. Hypoxia and hypercapnia are also related the severity of the COPD and linked to malnutrition. So we should focus also on the nutritional aspect, as well as whenever there is malnourished patients also suffered, as well as obesity is also uh, affect the pulmonary rehabilitation. So weight loss program should be started with the diet history, over or underweight, fat-free mass, quadriceps muscle strength, and the respiratory muscle strength are very useful. Vocational rehabilitation, vocational rehabilitation, if we can change, there is a changing of job, sitting job or homemade job, avoid pollution. These also very important. And sexual rehabilitation is very important because it otherwise it depress the patients whenever he is dissatisfied with his life and the partner. So talk with the partner to avoid bronchospasm, use in bronchodilator and other positions. Avoid alcohol, side to side positioning instead of top bottom positioning during this intercourse. Air table. So usually, most of the commercial airlines provide oxygen during the travel, but we should keep our oxygen cylinder, a small cylinder, with during the air travel. Outcome assessment through the different scales, Borg scale, 6 minute exercise testing, and so many questionnaires are there for this outcome. So these are the some grades of the evidence. Thank you.
Uh, Thank you, Dr. Gupta, for your wonderful presentation on this pulmonary rehabilitation. I'm Dr. Arnab Bera, consultant respiratory medicine from Medica Super Specialty Hospital, Kolkata. And now I'm going to give a talk about on smoking cessation. 31st May, that is the World No Tobacco Day, is coming. And thank you, CCI team, for giving me opportunity for giving a talk on this topic. And definitely, smoking is a concern for our young generation, for our the chronic lung patients, and it is a time to take ourselves against this tobacco. And if you go for the theme this year 2025, that is the unmasking the appeal, that is exposing industry tactics on tobacco and nicotine products. So basically, the industrial companies are making lucrative flavors and kind of packaging, but we have to prevent our young generation from these things, and we have to share with them the ill effects, the harmful effects of smoking, and definitely our patients also, because they are always a chronic lung patients. So first hand or second hand or third hand smoke is detrimental actually for them. So if we go for the chemical compounds in the cigarette, okay, so you can see that there are certain components like 7,357 chemical compounds in the cigarette smoke. Among them, 70 components are usually carcinogenic. To name some important components like nicotine, N-nitrosamine, benzenes, aromatic amines, aldehyde, 1,3-butadiene, acrolein, and polyaromatics. Okay, so the risk of smoking are like in form of some chronic diseases, like they can actually not only affect our lungs, heart, kidney, everything can be affected. So from brain, like stroke, blindness, gum infection, aortic rupture, heart disease, pneumonia, hardening or arteries like ischemic heart disease, chronic lung disease, reduced fertility and hip fracture, and the most important, like multiple cancers can be attributed to smoking, like head and neck, lung, leukemia, stomach, kidney, pancreas, colon, bladder, and cervix. So now you have to understand first the states of change. So we all are aware about these detrimental effects of smoking, and the states of change is like, first is the pre-contemplation. So there, when there is no intention of changing the behavior, then contemplation, where you are aware that a problem exists, but there's no commitment to action. Preparation means now you have an intent to take an action to address this problem. Action, that is the active modification of your behavior, and you have to maintain this sustained change. But relapse can happen, that you again fall back into your old pattern of behavior, and the spiral circle goes on. Now, World Health Organization, probably first time they have given a guideline on tobacco cessation in adults in 2024 July. You can all download this, okay, from the website, and you have to understand why people are dependent on tobacco. There's two type of dependence. First one is physiological dependence, that is the addiction to nicotine and which needs the treatment, that is medications. And one is the behavioral addiction, that is the habit of using tobacco, and the treatment would be the behavioral change program. We all know the negative impacts of smoking. You can almost gain almost 10 years if you stop smoking in your life. Okay. And there's multiple causes of death from smoking, like lung cancer, from heart disease, from COPD. Okay, every 1 in 5 deaths is probably due to related to smoking. And if you quit this smoking, you will save money, your energy level will increase, you have reduced health risks, your food will be taste better. So the algorithm, how will you approach for your clients or patients who are currently smoking? So if the patient does not smoke or never smoke, no intervention required. But if the client has smoked ever previously, so you have to prevent the relapse. You have to congratulate on success or reinforce the decision to quit. Now, if your client is now willing to quit, if not willing to quit, you have to motivate them, that like the 5R of motivation, like relevance, risk, reward of stopping, roadblocks, and repetition of the messages. And if they're willing to quit, so you have to give appropriate treatment actions, like 5 A's of intervention, like ask, advise, assess, assist, and arrange. I'm going to details like this 5R of smoking cessation, like relevance, why the quitting is personally relevant to them. What are the negative consequences of smoking? I have already told you. What are the rewards or benefit of smoking? So you can see even after 8 years, the nicotine and carbon monoxide level in your blood will decrease. After 24 hours, they are eliminated. After 48 hours, there is improved sense of taste and smell. 72 hours, easier breathing, increased feel of energy. 2 weeks to 3 months, improved circulation and physical activity. 1 to 9 months, reduced coughing and breathing problem. 1 year, reduced risk of ischemic heart disease. At 5 years, reduced risk of stroke. And at 10 years, reduced risk of lung cancer. What are the roadblocks? You have to identify the barriers of quitting, and you have to repeat this message on every visit. And what is the 5 A's of intervention? So you have to ask all patients about the tobacco use at every visit and record their status. You have to assess that patient is willing to quit in next 30 days. You have to advise them in a clear, strong, and personalized manner. To in every tobacco users, you have to assist, help all the users to stop based on their willingness to quit, and you have to schedule the follow-up. And you have to always keep in mind there's nicotine withdrawal symptoms, like feeling frustrated, irritable, angry, sad, depressed, anxious, or jumpy. You have trouble concentrating, trouble sleeping, increased appetite, but the most common symptoms are craving or urges to use nicotine, and you have to keep this in mind while you are doing this. So there are 7 FDA approved medication that can help patients quit smoking, available over the counter like patch, gum, or lozenge, available by prescription, that is varenicline, bupropion, nicotine nasal spray, or nicotine oral inhaler. So there are some short-acting medications, there are some long-acting medications, and you have to combine at least one short-acting control medication as a first-line therapy. You can combine varenicline or nicotine patch, and you have to give short-acting medications like gum, spray, or inhalers or lozenges to help this craving. And these are chart, the smokers within 30 minutes, smokes within 30 minutes of working, or smokes more than 30 minutes of working. And depending on the numbers, cigarette smokes per day, you can combine like patch with gum or lozenge or spray in this manner. So that is treatment part. Now the behavioral therapy. So behavioral therapy, you have to give this standard cognitive behavioral therapy. There is a book on practical guidebook to the most effective treatments. You can see this book also. But the important points to be worked on, that is the smoking addiction theory, mechanism of action of nicotine, the dependency type. Okay, you have to analyze the reasons why the patient is smoking, and abstinence, begin the pharmacological treatment to quit smoking. And you have to analyze the risk situation, strategies for better coping, and a relaxation technique. You have to give scientific information on how the smoking is harmful to your health, thoughts, emotion, and behavioral related abstinence. You have to restructure these cognitive functions. Okay, you have to train in problem solving. Okay, and advertising. Definitely nutrition is an important part, and you have to prevent the relapses also, and preparation for maintenance. So there is a thing on electronic cigarettes. Lots of patients are using electronic cigarettes for smoking cessation. There's an article on this NEGA. They have also told that addition of e-cigarettes to the standard smoking cessation basically resulted in a greater abstinence. But the increasing use of these e-cigarettes, particularly among young people, is a dangerous trend and a real health risk. For many patients, for many reasons, e-cigarettes should not be promoted as a safe alternative to smoking, because the cardiac problems may remain as it is. Okay. So now there is a newer drug, in the market, cytisinicline, is an effective and safe pharmacotherapy to promote smoking cessation, and there's a randomized trial also, and they have shown their efficacy and excellent tolerability. Another drug like semaglutide is used in patients with type 2 DM with tobacco use disorder, but that also need further research. And there's a called vaccine, that is TNIC vaccine. So basically what they are doing, once after inhalation, there's absorption of the nicotine material in the blood, and this free nicotine actually causing the blood-brain barrier and giving the dependence or feeling. But if you use this nicotine vaccine, this on the research level also, but not available, is on research level. This nicotine actually bind the free nicotines actually, and antibodies actually binding the free nicotines, and these are not able to pass the blood-brain barrier. The important part is you have to make your every day is a World No Tobacco Day, and you can visit quit smoking clinic, like the smoking cessation clinic. How will you just perform, or the things you have to understand while you are planning to make a smoking cessation clinic. So staffing and expertise are important, like trained professionals, including psychologists, social workers, or behavioral counselor. You have to continue the education and give them. They must have motivational skill. Clinic environment is important, like in private, comfortable area with supportive atmosphere. Comprehensive services are required, like pharmacological support, psychological support, follow-up arrangements. Referral system is important, that multiple departments can give you referrals when they got the smoker patients, and you have to need patient education materials. You have to do awareness campaigning inside the hospital and also outside the hospital, and you have to arrange your funds accordingly, and you need proper infrastructure for that. Now, artificial intelligence in coming in every segments of our life, and the smoking cessation technology that is also recognized with this AI, like personalized mobile applications, wearable devices, virtual reality therapy, social media platforms. AI chatbot can chats with you regarding your thinking of craving, and they can prevent the relapse. Okay, and sometimes they can engage yourself in gamings, or this kind of thing can be done with this AI. And the road ahead for AI in smoking cessation is like personalization, real-time intervention, community social support, predicting health outcomes, and continuous learning and adaptation. Those here multiple apps are now available. One I've given Quit Sense. This app looks like this. They are measuring your stress level, depression level, situations of craving, and there are other apps like Quit Now, Quit, Smoke Free, Quit. Multiple apps are there who actually helps you to prevent your craving and get yourself out from this smoking habit. Thank you. Thank you, CCI, for not smoking to everybody. Thank you. Now I hand over to Dr. Neel Thakkar for the panel discussion. Thank you.
A very good evening, and we are back with the panel discussion. So it was an amazing 2 sessions of discussion and presentation with experienced insights as well as experience by Dr. Gupta sir and Dr. Arnab Bera on the pulmonary rehab as well as various aspects of smoking cessation. We have already introduced majority of the panelists in the initial introduction. I think Dr. Vrushali has joined us now. Can you please?
Sorry, I joined you. Yeah.
Yeah. And we also have Dr. Ankush Chaudhary with us now. So Dr. Ankush Chaudhary is a senior consultant pulmonologist in Delhi. He is basically he has extensive experience with smoking cessation as well as rehabilitation as a program, and he's having an Indian innovation in this where he's developed a program specifically targeting and helping chronic smokers and severe addiction with behavioral change as well as an integrated management approach. So welcome, Dr. Ankush. He'll be part of the today's panel also together. So again, before we start off with the panel discussion, I'd done a small poll in our group, that is the Chest Council of India yesterday, where we had asked regarding the clinical approach of all clinicians in our CCI Life members regarding to their approach to smoking cessation and rehabilitation. So just to keep that in our discussion, majority, I think 46.5, so around 146 people had polled in that chat, and out of that around 46% do counsel patients regarding smoking cessation, around 18% do counsel regarding nicotine replacement therapy, as well as around 10 to 12% do involve a psychiatrist as well have a rehabilitation program in their place, around 10 to 12%. Anti-craving therapies, only 6% of the people who have voted do use. Questionnaires for assessment around 0.0, only 1%, and artificial intelligence use around 5%, and the utility of government services and an NGO is around 1.3%. So this is just because this is our own data. I just wanted to share before we start the panel. So the first question to Dr. Vrushali would be that as per Gold 2025, around 40% COPD patients are still current smokers. So before we start, so I'll just let's take a model case, a chronic smoker patient who has significant number of pack years, who has chronic cough, is evaluated, spirometry done, maybe Gold PFT staging around 3, and symptomatic with stage of E. So had a admission exacerbation in the last year and frequent exacerbation still happening. So significantly progressive disease on Gold, but patient is still a current smoker. Now in India at present with the cigarette, VD and even tobacco use, So my question here is, is the cause of nicotine addiction in such people? And if such a patient comes to your outpatient clinic, then how would you start the discussion of smoking cessation in such cases? Dr. Vrushali, please.
So Neel, what I've understood is this patient had IPT exacerbations as a patient.
Yeah.
So basically, in an outpatient department, how am I going to be intervening in
Suppose
this
this patient comes on a follow-up post-discharge.
Yeah. So ideally, let me just say that, when the IPD exacerbation is there, that is the best time to initiate the smoking cessation, because they've just suffered a major blow to their health and they are more receptive to the counseling. But here, saying so, even if the patient comes later, the IPD exacerbation was somewhere else and comes to you on an OPD basis, we go through what Dr. Arnab Bera has just told us, that first we have to ask them do they really smoke and how much is the intensity of smoking. So you have the Feigenbaum smoking test, which is there, which gives you the intensity. This is for us to decide as to what level of intervention might be needed in this person. So one, you have to ask every individual is that how much are they smoking, and whether it is just tobacco smoke or it is smokeless tobacco in addition, which is quite a common thing in the Indian scenario. Then your next job is obviously to advise. Now, during advice, generally, you just come around by how is the condition of the patient, why is it caused, and you believe that, the smoking is also a major risk factor. Not also, you could emphasize that it is a major risk factor, and it would help this individual by further reducing the further triggers which are there for his exacerbation, might helping along with the other aspects, that is pulmonary rehabilitation, the pharmacotherapy for his condition, maybe COPD, maybe ILD, maybe whatever lung cancer and things like that. Even for that matter, patients who have just had an ACS or a myocardial infarction, these are also very receptive. So these people, this is the best time to urge them to strongly avoid smoking. And let me say that, today there was a lot of talk on empathy. So generally, do not have the tone of, an authoritative kind of a tone. Do not say that, what you're doing is wrong. Just be empathic that, we know as medical practitioners that why nicotine dependence occurs. I think I'll come to that question of yours later. So you have to give them a very, offer them that they should be advising, then offer them support whenever you are advising them to stop smoking. After you've advised, you need to assess whether they're ready. So Dr. Arnab Bera has again given us a beautiful, there's no pre-contemplative, contemplative, then they're ready, they're preparing, then what action is to be taken and how to maintain that. So that has to be assessed, and always try to understand why an individual is not ready. If they are, even if they're not ready, try to go around it and try to ensure that the person becomes ready in the next visit or so, and also involve the family or whatever is his support group at home, or maybe amongst his family and amongst his friends, and also as in his workplace. Then the other thing is, once you've advised, you've assessed whether the willingness is there, the next thing you're going to do is assist the individual. So again, he's given us a beautiful thing, and as to how you're going to assist the individual, stop smoking or quit smoking. In that, you have to give them, a particular quit date. You might have to just see whether it is only counseling, some amount of behavioral therapy, taking away the reasons why the individual took up to smoking first, taking out the environment. Suppose, it's usually friends are meeting, then we smoke. It's usually I go for a coffee and I smoke. It's before I present something in my meeting, as an office meeting, I smoke. So if you can do something to tailor these environments so that his urge to smoke in that environment goes down, this is how you assist. And finally, you're going to arrange a follow-up once the patient has been on an assisted kind of a therapy to quit smoking. Now, let me come back to the question where you said that why do you think there is nicotine in the addiction? One, which is very well known to us, that a single puff of smoke, it immediately, the nicotine, it activates your dopaminergic pathway in the brain. And that is a real quick. So it is said between 5 and 10 seconds after you take a single puff that you feel a pleasure, you feel comfortable, it's a different level altogether. And therefore, it is quite difficult for any individual to get over this. So one, with every smoke, what happens, they develop a level of tolerance. That is, suppose 2 cigarettes are causing this kind of a thing. Next time it's going to be 4, 6, and eventually it's going to keep on growing. Even if some person decides that I want to quit smoking, there are a lot of withdrawal symptoms. Therefore, empathy that, let me help you. Regarding where this addiction starts. So in Indian setup, there's a beautiful study, one of our doctors, Dr. Gangwal, who is, he is quite instrumental in the tobacco chewing, and and gutka, basically is a crusader for that. What they found is that what these people did was they started parking their packets outside schools and colleges, and where they used to give flavored substances, and it is to be given free of cost. So this is how first they are introduced to the subject, the whatever pack, maybe it be gutka, tobacco in some form, or the smoked tobacco, flavors, various flavors, and then eventually once it's affected their brain, then they have this addiction. I hope that answers your question. Neel, you want anything specifically? I could happily go on.
That kind of summarizes both how you approach and the pathway for addiction. So a lot of times, like just there's an acronym that we use that we normally follow film stars. Like a lot of film stars say that bolo, like you have all film stars in majority advertising for tobacco. So they are all stars. So you can just use the acronym STAR when you have a patient in your OPD. You set a quit date. You tell everyone. You ask them to tell all their friends and colleagues. You tell them to anticipate challenges, and you remove the tobacco from the surroundings. It's just a small acronym which we can tell our patients, which may help in such case scenarios. So now the second question to Dr. Arnab Bera. What are the main dangers or harmful effects of smoking to the lung as well as to the other organ systems? Especially in the Indian context, we have almost 154 deaths every hour in India because of causes related to tobacco, and almost 3,700 deaths per day because of smoking. So what harmful effects would you explain to patients or for the audience here, that what are the harmful effects of smoking?
So, see, Dr. Neel, thank you. Basically, I have shown in my presentation also, there is that more than, almost more than 7,000 chemical compounds are there in the smoke, but among them, almost 70 are actually carcinogenic. So, basically, see, lung problem, everybody is know that there is a risk of lung cancer, risk of COPD or chronic lung disease. But smoking can affect many organs in our body, from our hair to toe. Basically, that smoking has an increase. If I go for a non-cancer part first, the risk of, there is a risk of stroke, risk of blindness, gum infection, bad smell, ischemic heart disease, okay, reduced fertility, and risk of fractures are there. But if you go for the cancer part, that is not only lung cancer, you have to understand. So smoking can cause, I have already shown that it can cause head neck cancers, it can cause leukemia, it can cause stomach cancer, pancreatic cancer, kidney cancer, colon, bladder, cervix. So there are risks are there, and I don't understand why the people, after knowing all these things, okay, despite the smoke, even they see the the images on the in the cigarette packets, okay, the deadly images are there in the cigarette packets despite the smoke. Thank you, Neel.
Thank you so much, sir. So again, with this, I would also mention here that besides the health effects which you have elaborately presented in your presentation and mentioned right now, the tobacco itself also, the packets harm the environment. So up to 10 billion cigarettes are disposed in the environment every day, as per the World Health Organization. And it contains many toxic chemicals, the butts of which are deposited in coastal and urban cleanup areas. And these emissions contribute to tons of human carcinogens as well as greenhouse gases. So even disposing that, besides ourselves, it does cause harm to the environment also. So again, we have, I think, Dr. Ankush with us for a limited time right now because, Dr. Ankush, if you would please want to share with us regarding your experience, especially like sir has mentioned, if somebody is seeing a packet के ऊपर ऐसा कैंसर के images है, still they are continuing to smoke. सारे डॉक्टर बता रहे हैं फिर भी वो स्मोक करे ही जा रहे हैं. We had this patient which case scenario I discussed with Dr. Vrushali. So if such a patient is coming to you, like if you have to, with your experience in this, how do you go about in making sure that that addiction goes away? Please.
Okay. Am I audible?
Yes, yes.
Yes. Okay. So first of all, as Dr. Arnab mentioned, the amazing pictures which are there, the taglines are there, smoking kills, and these are fear-based approach. As I mentioned in the morning in the group also, fear-based approach does not work for any behavior change. Just consider ourselves. Don't we all know that smoking is harmful, alcohol is harmful, consuming too much of mobile phones, reels is harmful, and still we are addicted to it. Because what I would like each one of you to understand, which I also understood in 2017 till the point I was also a smoker. Okay, so Dr. Neel knows me from those days, but maybe he might not be knowing that I used to be a smoker. Okay, and I overcame this addiction because of a life challenge. And I would like to tell each one of you, whosoever is watching, I was bedridden for close to 6 months, and still I was smoking. Behaviors are subconscious patterns. Okay, and we don't change with fear based psychology. It is very limited people, like less than 7% of the people they leave. 15 minutes लगेंगे also. 50 less than 7% of the people, they change their behaviors with the fear based psychology also. And the quit smoking, the word itself, it's a paradox. People will not like to quit anything. Okay, once you tell them that you quit smoking, it does not go as per the norms of the linguistic psychology. So rather than that, you have to reframe or rephrase it to something like that quitters are winners. Have you heard of this phrase, that quitters are winners in this context? And so for our program, we have named it as smoke free life. Freedom is what everybody desires for. Okay, and that would motivate them enough. Also, coming to your second part of the question, that what would I be doing? I do not use traditional kind of questioning models. Okay, I use only one point assessment, that are you willing to quit? There are two kind of patients, those who come to us. In two categories, I will only bucket them. That either they have been brought by force by family members, or they understand that I am having an addiction and I just need help. That's it. I'm not even going after their willingness, or whether how much determined they are. They just have to say that I am willing to quit, but I'm unable to quit and I need help. That's it. That's the only enrollment criteria we have in our programs. And so I've shared on the group, I follow something called as a neurological level structure. So neurological level is a 6-point hierarchy wherein we assess the person. Where is the person lacking the most? Where will this person need the most amount of help? Whether it's a behavior, whether it's an environment, going from down to top, whether it's an environmental change the person needs, whether it's a behavioral pattern which the person needs, strategies, which whether they are lacking in strategies. And this is all unconscious in nature, unconscious patterns I'm telling about. Behaviors, strategies, values and beliefs, then identity, and goes to vision and mission. There are plenty of stuff which we do in our counseling sessions, for which we have already crafted a module, okay, which is available online. Any one of us can access it, and it's a 9-day program. Okay, and the results are amazing. I did not quit smoking with nicotine replacement therapy. I was on vernicillin, but couldn't help me. At that point in time, I was still, because I was bedridden, it was a significant health crisis to me. I was on antidepressants as well. 3 of the psychiatrist friends, top-notch doctors from the country, were treating, but still could not help, unless cognitive neurogenesis was introduced to me. And majority of you might be surprised to know that for that person to help me, whosoever that person was, he is a trainer to me now, a very good friend, it took him only 1 hour. There are plenty of YouTube testimonials from our patients only, wherein we have helped them overcome this addiction within 1 hour, 1 session to 2 sessions. Okay, so that's all in the limited time I can share.
Thank you. Thank you so much. So we have been fortunate that you have been so honest and transparent with us, especially sharing your own. It takes courage to share your own experience in a public forum like this, and it will surely inspire many of us, as well as we can use such forums as well as I think Indian innovations. That is what I would call it. That we have our own people who are working towards this cause. So we should
So, Dr. Neel,
Yes.
before leaving, I would like to mention that many of the models Dr. Arnab Bera mentioned, that smoking cessation apps are available, like QuitSure is available. Then
Yes.
there are other apps are available. All these are modifications from a very good system which is available worldwide, LNCAR system. Some of you might have heard, for some of you it might be new. So LNCAR system is also based upon cognitive behavior therapy, hypnotherapy. And what I have done after training with my mentor, Ted Bradley from Australia, that
Yeah.
we have refined that system further. We have taken the success levels to another level. So he jokingly says this to me, that only person I tell this to him, that only person who has got more success rates than me is my mentor, Ted Bradley. That's it. We have surpassed the success rates of Alan Carr system. Okay, and it's still a very good system, Alan Carr as well.
Thank you. Thank you so much for sharing your experience, Doctor. And again, coming to the next question, we have with us Dr. Chaithanya Madam with us. So, what are the beneficial effects of stopping smoking with a timeline from days, months to years, as per your experience? And normally, if you have to counsel a patient to stop smoking, would it be at one go as a cold turkey method, or you would want it to be a more gradual over a period of time, madam?
Yeah, thanks, Dr. Neel. That was a great question because we encountered this in our everyday practice. And we have now heard from Dr. Arnab that there will be a lot of hazardous effect of tobacco smoking. So for that is like a counsel of fear. That's what we instill usually sometimes to tell the patients that this is not good and everything. So apart from that, I think it's better on a soft corner to tell them what are the rewards they are going to achieve after smoking cessation. So to just summarize them, once a patient, all these benefits usually appear more in patients with age, in people with age group of less than 50 years, they will have more beneficial effects if they quit smoking early than late. But apart from lung per se, overall also there are a lot of benefits of quitting smoking. Smoking halves the risk of dying in the next 15 years compared to people who continue to smoke, and decreases the lung incidence of lung cancer to approximately half over the next 10 years, and 1/6 in the next 15 years. And the well-known thing, and which is being advertised also, that risk of MI approaches to non-smoking level in approximately 1 year of abstinence. And not of women smoking, female smoking also we are seeing these days. So women who quit smoking in the first 3 to 4 months of their pregnancy can have no low birth weight kids actually. So apart from that, from the lung point of view, we all know the famous chart of lung function decline and everything. So smokers tend to lose their lung function more than a normal aging individual. So in that, if we stop smoking, FEV1 improves in 3 months, and their accelerated lung function decline also will come down. And apart from that, in patients with chronic bronchitis, there will be decreased mucus production also in these individuals. So when we counsel the patients that these are the advantages of quitting smoking, then the next question they'll ask, a lot of times we hear, if we stop smoking, suddenly we'll be having a lot of side effects and everything. So most of the studies which were done, like the Cochrane review and the recent studies from China, etc., everyone proved that absolute abstinence from the day of the counseling is more better than a gradual decline, unless and until patient will be having rebound incidents of cravings or anything. But most of the times we have to tell the patient that at this point, just quit the smoking and decide a day, inform your peer group, inform your friends and family, and from that day stop smoking. Along with that, we have to provide some behavioral counseling, along with that some pharmacological therapy if the patient needs, and schedule some follow-up so that we'll have an overall we can help him in the process of quitting smoking.
Thank you. Thank you so much for an elaborate answer and sharing all the benefits of quitting. So because you mentioned pregnancy, again, there are 3 stages. Pregnancy, when the patient has a new child in the home, or there is a death in the family. So these 3 are some situations when, if the patient is in follow-up with you who's a chronic smoker, there could be a high likelihood that the patient will quit during this time. If you counsel them properly with this specific 3 time periods, if there is some pregnancy, death, or some newborn coming in the house, so you can explain regarding these benefits of stopping smoking to them as well as their family. So coming to the next question, Dr. Gupta sir, what is the 5A 5R model in smoking cessation, and do you use it in your outpatient and IPD patients on discharge?
Dr. Neel, smoking cessation is really a very, very challenge, because as Dr. Arnab and saying and Dr. Ashish is saying, nobody wants to quit. But by motivational as well as with the structure approach, we can motivate them by using these our approaches 5A and 5R. 5A and 5R basically they are two models. 5A for those who are ready to quit smoking, and 5R for those who are not ready to quit smoking. So 5A is, as Dr. Arnab already said, this is ask, advise, assess, assist, and arrange. These 5A. So first of all, identify and documentation. Advice for the quitting of the smoking. Then assess. Assess the amount of the tobacco, cigarette of the tobacco, or the BD and other hookah in the rural areas. This is very common in the rural areas. Hookah is very common. And those who want to quit, we should assist a program for them and arrange. As well as, but those patients who don't want to will quit smoking, so we should motivate them. What is the relevance for the quitting the smoking? What are the risks of using the tobacco smoke? And so we should also some rewards whenever he try to quit smoking. And also we should identify what are the roadblocks. If a person wants to quit smoking, so what are the mainly roadblocks? Their peer groups or society booms on like this. These are some. And what are the repetitions? So what are the repetitions? Repetitions we try to more and more repeatedly. But as you tell, in busy OPD, it's not every time possible to follow all these rules. So in a short, ask, advise, and refer. AAR. Yeah. So it's a very short. So we can use ask, advise, and if possible, refer to a concerned person like a psychiatrist for early results and for the motivationals. Dr. Neel, please unmute.
Thank you, sir, for summarizing the 5A 5R approach as well as sharing your AAR approach, where we should work in a team and try to make sure that we fight this addiction in a coordinated and a systematic manner. Now, as you mentioned, it is not possible to do all this ourselves, or a lot of time we need help of others in this. So my next question comes to the utility of artificial intelligence to help us in this. So Dr. Arnab, with the use of, again, we have a lot of electronic medical record systems which are used in most of the urban hospitals now. So do you feel any AI enabled alerts, or with the digital storage of all the patient profiles that you have, can this help you in flagging active smokers and as well as with other interventions for smoking cessation? And otherwise, do you utilize AI in any way as of now in your practice for as in the smoking cessation clinic, please?
Okay, so regarding you are telling na that electronic medical records part, the problem with this our corporate hospitals are na the maximum patients are some kind of insurance patients, okay, some and they actually suppress the fact in fear of the insurance might be cancelled if they declare they are smoker. So this thing actually is not happened as a way it should be in the corporate hospital. Okay. But what we can emphasize to our fellow colleagues, they don't suppress the fact in front of doctors. Actually, probably in the record it may be not there, but so inter-departmental relationship. Okay, so you have to aware the other departments once they are getting smokers, they give us a alert, and if they are willing to, they can send us to the patients. Definitely for so cash patients or other kind of thing, maybe we can get a record, but if in for corporate patients, it always not possible practically. And regarding your second part, that is the AI part, I have told you in my presentation also that definitely if you ask that I have used it or not, I have definitely used the apps only. But the AI is coming in a very much bigger way apart from this app. So there might there maybe that these personal mobile applications or app is must be there. But there are some kind of wearable devices like Beat, or you can the AI is using some kind of virtual reality therapy. Means they are showing if you not smoke, how the world would change in front of you in a sort of virtual reality therapy. And they can link you with the other social media platforms or the other people who are actually want to quit the smoke. And there is a kind of AI chatbot kind of thing, artificial intelligence chatbot, that is open for 24/7, where you, if you want help, you can chat with them artificially. They will some kind of behavioral therapy they will give you artificially. And also important that AI is actually predicting the relapses. When there is a chance of relapse, the chance of craving, they are engaging you some kind of gamification, some games or kind of thing, keeping your mind busy in some other works, so that this craving does not happen. So definitely AI is coming in a bigger way. We have not used it in such a bigger way. We are using some kind of apps, advise the patients of app, but definitely in future it will revolutionize the smoking cessation therapies.
Thank you. Thank you so much. And again, you mentioned regarding apps. So just because we had a discussion earlier also with Dr. Ankush regarding some of the apps. In India, there are, I think, 4 or 5 applications for helping quitting smoking. One is he had mentioned was Quit Genius. So now that is, again, it has behavioral therapy as part of the application, interactive sessions, progress tracking. There is the Easy Quit app where again, besides you mentioned games, gamification. So what happens is it distracts and kind of whenever you have that craving, you go on the app and it gamifies that dopamine surge. So similarly, also the financial incentives. So if you enter your profile, your annual income, your monthly income, it will eventually show you that suppose you're not smoking, this is the amount you keep saving. So that is also one incentive where we counsel patients that if you spend this much money in a FD or you take stocks or you spend on equity, the same amount that you're spending on your cigarettes or VD or whatever vaping in the now we have a lot of college students coming with vaping. So same thing you can earn or save so much money if you do that. So that is some, and one more is Quit app and Quit Tracker. So 5 apps which are now there for helping with smoking cessation. So again, the next question now to Dr. Vrushali, coming back to you, is that if you have various people, like we discussed that case. So if you have this same person coming in from a village using tobacco, BD, same person from the city who's saying I have cigars, cigarettes, or in college students, as I mentioned, now vaping is the in thing right now. So what would it make a difference as to the mode by which they are consuming smoke or tobacco or nicotine, or how does it affect the respiratory health? Please unmute if possible.
That's an excellent question. It's a very important point that we approach all 3 cases differently. Maybe the rural, the urban, and you have a young adult who comes to you with the latest hookah and possibly the vaping as well. So everything we all know that the BD smoking is much more toxic in terms of higher nicotine content and also the other tar chemicals which are present. There is no filter in that, and you have to really take a deep breath to kind of burn that tendu leaf. So you have much more chemicals going in, and there is an increased risk of the same problems which occur with smoking to happen with BD. Now, coming to what are the factors? So generally, BD and tobacco is like a norm in the rural population. Not only amongst men, but find so many of the women using tobacco or even the misries. So here it becomes a little difficult because it is kind of ingrained in them, to tell them that, this is something which is now currently responsible for your problem. Because they do not realize, their understanding of the gravity of the situation, and that their habit is responsible for whatever complications they're having, is quite difficult for them to understand. So I think it takes a little time in that sense in these people, that, to make them aware that this is the reason. But at the same time, these individuals are receptive to whatever is being told by a doctor in a city. They generally do not doubt. They're the less doubting variety. They're the less Googling variety. So we just have to, concentrate and continue, persist and pursue them, that, this is something, just do it once. Let's see how it is affecting you. So that's why I think, and then, all these apps which we just discussed are of limited use or possibly no use in a rural setup, right? Now, in an urban setup, the smoking is generally, it is a peer pressure. Once you've been introduced to it, then the environment, and then it becomes more of a status kind of an issue. And quitting or maybe, becoming smoke-free is looked upon as someone who is, doesn't have the strength or the ability to carry on, that you're kind of darpok, dar raha hai karke. So that is some myth which you have to take away. Also, they have to be taken, the myth of, that vaping is safe. It doesn't contain nicotine, but it has formaldehyde, it has other chemicals. And the same concept that, you have this concept where you are smoking something or you're inhaling something that ensures that these people they can go back to cigarette smoking also. Plus, they also have this concept that hookah is just a flavor. So, but there's smoke, there's carbon monoxide. So there are some kind of misconceptions that this is safe and this is not. That this has to be something which has to be told adequately to them. And in these individuals, possibly the mobile apps and the web-based applications help. In young adults, because they have not actually developed some complications, but you can show them images. Possibly all of us can have images in this, not only about the gory oral cancers, for those who are using smokeless tobacco, and for the lung cancers, but also, like you just mentioned, environmental health. Though generally what I see is people are like, we are not bothered about ourselves, what about the environment? Social, yes. So suppose there's somebody in the family who is having COPD, who is having heart disease, you can, put that in front, that, your smoking might affect that individual's this. You just said that someone who's just died, there's a newborn. So this is how it differs in the various things. So in rural, you can persist. In urban, you can actually, in this case, I actually ask them to Google, to save on my time, but give time every single time.
Excellent. Thank you so much, ma'am. So just with this again, in specifically urban, with vaping, we also have this risk of acute lung injury.
Diwali.
And also we can demonstrate, like in all these separate, suppose we either with using a video, or if we have something that simply just putting a cigarette in a glass, or there are a lot of online videos also which are available which show virtually that how much it damages the lung. So some kind of a demonstration with the counseling during this, with whichever modality they are addicted to, may help us. So again, coming back to Dr. Chaithanya, madam, if you have we discussed a case scenario of a gold group E. So again, stage 3 by spirometry, but group E patient who has persistent symptoms. Now you have tried your hand with counseling extensively, but they are not able to stop. So then now you have to come to what pharmacotherapic options say. How do you combine pharmacotherapy or with behavioral support in your patients? And with the use of pharmacotherapy, have you observed or are there any likely side effects possible with these drugs, madam?
Yeah, that's a relevant question actually, because we frequently see these patients who are like the E group of COPD patients who already had an exacerbation in the previous year or whatever. They are more dependent on nicotine. If they are still smoking at that point of time, they are still more dependent on nicotine. Definitely pharmacotherapy is needed at this stage. But most of the times what will happen, like if we read globally also, like only 1/3 of patients use pharmacotherapy. So a lot of these patients, apart from pharmacotherapy, needs a lot of behavioral therapy. We know that there are nicotine replacement therapies along with varenicline and bupropion, which are there in the market. But despite that, they need to have a proper behavioral therapy for these patients. So that we should make the patient aware of that what is their own lifestyle and are they self-efficient to quit smoking, and what is the capability to understand the change that occurs in their body, and how can they self-regulate themselves and how can they monitor themselves. So we have to it's always better to send them to a behavior therapist, but if not available in all scenarios, at least we have to take that initiative to start that counseling or that therapy kind of thing. So there are some proven models like a PERMA model, like positive emotions which they are affiliated to, like whatever which will improve their mood and everything. So to always be in this positive emotions, and along with that, E means engagement, like get engaged in work activities, like rather than sitting idly then again try to smoke. So engage in activities like gardening or doing something with their hands, activities and everything, and maintain good relationship with the family, peers, and with their doctors or whatever therapists, whatever is who are they are aligned to. And along with that, have the meaning of life and like mindfulness and like meditation. All this also will help them with the behavioral therapy. Along with that, like we have to show them like after all these changes, what are they going to achieve. So this PERMA model, I think if we can include in our regular counsel and keep on stressing these patients, I think that will be useful. And a lot of times we need all these combination therapies, because if the nicotine replacement therapies are the one go or like the magic drugs, then we need not discuss about all these things. But they have significant side effects, especially the nicotine gums, which are more easily available. They'll be having like frequently initially the patient is smoking very high cigarettes, like more than 20. They need a lot of gums to overcome those cravings. Like every 2 hours, they need to take the gums, which will cause like automatically, if we are chewing that, induce our gastric acid secretions, and they're usually contraindicated in ulcer patients and everyone. So GERD is one thing which we frequently encounter, and that irritation of the mouth, and patients won't be, after some days, they lose the taste in they cannot eat properly. So a lot of distaste and all these things they'll encounter. And compared to that, I think nicotine patches are slightly better, I feel. Based on that, the doses are available. But only thing with nicotine patches, sometimes few people may get a rash, but majority of them will tolerate. And nicotine patches, but they can't give that high surge of nicotine to reduce the craving. It will give some level of nicotine in the body, but that surges cannot be given by the nicotine patches. So a lot of people tend to stop keeping them. And the famous varenicline, which was thought to be a game changer in the therapy, but a lot of people are we're not able to use, because I have prescribed for one of my relative and he developed a lot of suicidal tendencies. And they'll be having this nausea, vomiting sensation and everything, and a lot of GI upset with varenicline, which again makes it's not very suitable. So like rather than giving one type of NRT, I feel that a combination will be more helpful, like keeping on a baseline nicotine patch and giving on add-on chewing gums, which will reduce the oral side effects also, and can, I think, maintain that nicotine level till the patient quits.
Thank you. Thank you so much for a extensive and an elaborate answer. And madam, again, so one of the effects you mentioned, the basic effects of all these drugs, but this was presented by a postgraduate at BronchoCon recently in Delhi. So if in government centers, they are giving nicotine replacement therapy for free in the de-addiction centers. So there was a case, he had a case series where multiple free nicotine tablets were taken. So the patient was given this dose to be taken limited this time, but all of them used to overdose themselves plus use it with IV drug therapy, and they found acute interstitial pneumonitis, an entire case series in a limited population because of overdose of nicotine as well as IV drug abuse with that in those patients. So again, they then went back to that locality, make sure now that it is taken under observation like dots in that government center. So again, counseling and behavioral support with nicotine replacement is very important. Otherwise, all these replacement therapies, if taken in an overdose, especially with IV drug abuse, can cause further problems. So a combination with counseling, behavioral support is absolutely essential when we use nicotine replacement therapy. So again, coming to Dr. Gupta sir, So depression is very common in smokers with COPD as a comorbidity. You did mention that we refer. So now in such cases, if do you feel that is it needed in all smokers, or how do you go about in referring such cases? In which cases do you feel need a psychiatric assessment?
Yeah, Dr. Neel, very rightly said, depression is the effect of the nicotine, because wherever in some patients there is a mood elevator or relaxing or like this, but ultimately in a long term it causes depression and anxiety, because there is a persistent craving for the smoking or the smokeless tobacco using this. Whenever there is a depression, the patient smoke more and more, and that affect more respiratory symptoms. So again, there is a more respiratory distress and again more anxiety. So there is a vicious cycle started with this: more depression, more tobacco smoke, and the more anxiety. So there is a, as you told, sometimes in depressions, there may be chances of the high dose of the nicotine ingestion in the form of the smokeless tobacco like zarda, gutka, and like this, as well as smoke. And in young adults, especially who are the college going students, because of the heavy burden of the pressures of the study during the night studies, they smoke a lot in the hostels and the even in the schools, secondary schools. So there is a increased utilization of the smoke, and also there is a tushan like this. Some as you told in the villages and the families and the smoking is a tushan. So they use more and more smoke, but whenever there is a unfavorable some circumstances, and then patient goes into depression, they smoke more and more. So there is a vicious cycle started. So in this case, we should seek the help of the psychiatrist
Definitely.
as well as to treat the respiratory symptoms. Along with this, we also use some anxiety, SSRIs or SNRIs or other. So as well as counseling of the parents and the peer groups. Very important during this period, because in depression, especially in the college going or some if a patients only already have some loans, already have loans, so there is again vicious cycle started:
Yes,
more
yes,
depression, more smoke inhalation, more respiratory anxiety, more respiratory distress.
definitely.
Yeah,
It's
so
a
very very
vicious cycle.
harmful.
Yes, yes. It's a
Yeah,
vicious cycle. So in such cases, we should definitely go for psychiatric assessment.
yeah,
And again, we have I'm happy to inform, I think I just received a message from Dr. Krishna that we have around 1,500 logins in our webinar today. So a lot of people have joined us. One of the audience question has come up. So again, Dr. Arnab, are there any government helplines or any government initiatives which can help in smoking cessation, especially in the rural population, if they cannot afford to visit a psychiatrist? Is there any government initiatives which help such
Yes, sir,
patients?
yes. So basically, we have talked about apps. So from the government part, there's a national tobacco quitline services number you can got online. I just remember don't remember the number, but it is available online. Okay, so definitely use this number to call them. But even I told you, you have to understand the state of change. So if the patient is in pre-contemplation phase, you can't do anything, even with the government number or apps kind of thing. At least the patient should be in a contemplation phase or a preparation phase. At that time, if you approach this patient with government headlines or whatever these apps are, the apps are quite good. You have just shown that they can show you how much they have saved the money kind of thing. Okay, they can help you. And okay, but definitely the main thing is that the patient should be motivated. Okay.
Thank you. Thank you so much. So again, Dr. Vrushali, with this same line of thinking, if there is a tuberculosis patient, so number one, under the RNTCP program, as well as in as per the guidelines, are there any initiatives for smoking cessation under RNTCP? And practically speaking, when you refer a patient for DOTS therapy, have you come across any initiatives for smoking cessation in such patients? Please, Dr. Vrushali.
Yeah, thanks, Neel. One thing which we have to know is that a person who's a smoker has a more increased risk of infection. Also, these people who are addicted, they possibly might default and they can have a relapse because of that, the higher rates. And now, regarding the RNTCP program, so there is in the Nikshay ID that you have to, at the outset, when we are initiating the patient onto the DOTS therapy, you have to mention whether the asks, whatever we have been asking, they have to ask. The DOTS provider has to ask whether the person is smoking. Once they have assessed that, they have also been trained to advise these individuals on quitting smoking, and they also assist. So assistance can be at their level, or they can refer them to certain centers which are under the National Tuberculosis Control Program, which actually every district level hospital should be having an assistance for these individuals. Like you just said that in a rural setup, they are giving the NRTs for these individuals. So basically, even in the NTEP, we have smoking taken as an important part. It is taken cognizance of, and there are efforts by these DOTS provider to help these people quit. Saying so, personally, I have never encountered this with because I'm been having a kind of a relationship with the NTEP program. So I prescribe and send over to them in the last 10 years, or possibly I have not looked into it. So this webinar actually served me as that next time I can look into whatever is actually happening. Yeah.
Thank you, ma'am. So again, it is the message here is that it is part of the program, and again, the indication here is that when we are targeting a TB-free India, a lot of times smoking aggravates to the treatment failures of TB also. So that is the reason why they want that if we are able to battle TB, we also need to battle the pandemic of smoking in our country. So again, coming to Dr. Chaithanya madam again, in patients with anxiety, tuberculosis or diabetes, what are your considerations when you plan smoking cessation? And how do you manage a relapse if a patient, say that model case coming again, as Dr. Vrushali has seen that patient, counseled extensively, that patient has left smoking. Now suddenly after a year, that patient moves to your city and again goes into a group and starts smoking again and comes to you that this is my history, I had to purge and I started again. So now how do you go about in managing such case?
Coming to the first part, it's really tricky because COPD patients, oxygen dependency, already depressed, anxious about their outcomes and everything. Second, and all these pharmacological therapies, again cause lot of restlessness, palpitations, anxiety and everything. So dealing with anxiety along with smoking cessation is a very difficult task, I feel. So in these scenarios, we have to give a lot of behavioral therapy and counseling for these patients. We have to spend extra time with the patients and do a lot of counseling for these patients, because whenever we give some or the other NRT for these patients, they'll definitely come back saying that they are having some certain side effects. So it's I think start slow, and predominantly counseling and behavioral therapy is lot needed for patients who are having anxiety, and sometimes antidepressants or anti-anxiety pills may help along with a psychiatric evaluation for these patients. Coming to diabetes, I think these people, once they start quitting smoking, they tend to gain weight because that chronic inflammatory effect of nicotine will be lost, right? So they will gain approximately 4 to 5 kilos of weight. And people feel that they're gaining weight and they are losing their physique. Majority of the smokers will be thin and smart and they look that. So, but once they gain weight, they feel that because I'm stopping and now I'm gaining weight, and if majority of them will be having comorbidities, right? So they feel that diabetes is not under control now because of my weight gain. So this is not a good sign of thing. And so we have to counsel them that that weight gain will be only during the initial period when they stop smoking, and with healthy lifestyles and like good hygienic, like good proper food and everything, they can control their diabetes also. And eventually with more workout, and they feel, because after stopping nicotine, their taste buds improve, they'll feel more like eating. So all this cause weight gain, and we can counsel them that this stays only for a certain period, and like adjustment of your medications initially along with healthy eating habits and physical exercise will help in managing their diabetes. Coming to management of tuberculosis along with smoking cessation, as like we already knew that because of these side effects of the chewing gums and everything, like tolerability of ATT will be becoming difficult if we combine both. Like already ATT will be having this GI side effects a lot, and apart from that, if we give all these NRTs, they'll be having that GI side effects. And if they stop taking medications like ATT, then it will worsen. So I think we have to counsel them, place the medications accordingly, like give more of proper behavioral therapy again for TB patients so that they won't miss their ATT for these patients specifically. And coming to relapse, I think again, when there are two things like a lapse and relapse. Lapse means like they'll come back to smoking, but not in a previous level. But relapse means they'll completely come back to their previous levels of smoking. So to prevent this, like whenever only initial counseling is not enough. So whenever we are counseling a patient, we should definitely schedule a follow-up meeting. Anyway, we'll write a review after 2 months or 3 months after prescribing medications. At that time, we again have to emphasize on their smoking cessation, like whether they have really quit or not. And if they are not quitting, or if they are lapsing or relapsing, then what are the triggers of that? Like passing through a cigarette shop, or peer pressure, or like depression or anxiety, or lack of family support. And we have to address those particular things in them, take some time, talk with them, address those issues, and say that like these lapses or relapses are like waves and they keep on coming, but they can easily overcome that. And that craving part is only for few minutes or like some time only, and after that, that will settle down. So during that time, they should be able to control themselves. So by, I think, like counseling all these avoidance of the trigger factors and helping them to avoid those craves, like how to avoid like drinking water when they are having craving, or like eating some healthy snacks while if they are having craving. So all these like small tips will help them to prevent relapse.
Thank you. Thank you so much, ma'am, for extensively explaining both regarding the comorbid illness as well as how to manage in a case of a relapse. So again, coming back to Dr. Gupta, sir. So if you have, considering you're a senior faculty as well as in a lot of teaching positions, if you have to suggest, and you, I think, also been part with the government delegation in a lot of places. So if you have to say in the policy making in DNB, in medical colleges, in DNB courses run in corporate hospitals, should the cessation success rate become a quality care metric? So if suppose if you want to have a DNB program, if you want to have as part of the NABH accreditation of the department, should it be that they should take smoking cessation rates? Will it help in curbing this addiction problem? And how, if at all, if can we implement this, sir?
Definitely, Dr. Neel. It should be a part of the DNB as well as MD and so on studies, because it's the response, because medical college and the leading private hospitals and are the face of the government as well as non-government organizations, private hospitals, leading hospitals are. Whenever a specialist is prepared, whether the DNB or MD, he should know about the smoking cessation techniques because it impact a lot. So there should be regularization, there is be drafting, there is be policy by the NMC for the smoking cessations. Just not only written chapters in the books. It's not sufficient because it is of utmost importance there is a rational, because it impact public health impact. This is also a clinical responsibility of a doctor to start a smoking cessation program, as well as it also has a educational value, and there is it also strength our system. So to aware during the guidelines, and the formation of the guidelines, and for the DNB examination or the MD examinations or the DM examinations, it should be mentioned in the logbooks and the assessments according to the logbooks. So what program you have assessed, how much patients you have seen, and how you implement the program in your ward postings, in your day-to-day practice, in your OPDs, in your IPDs. Because respiratory physicians have seen so many patients who are smoking, COPD, bronchiectasis, lung carcinoma, and other comorbidities, cardiac disease, as Dr. Chaithanya said, diabetes, and so many, and also as well as uh, tuberculosis. So there is a add-on risk with the increasing smoking. So if we include in the curriculum and the as well as assessment part, and the how we calculate what is the success rate, 30-day free trial for the 3 months. So it should be assessed, and it should be mentioned in the scoring during the final examinations. So at least at the government level, NMC level, it should draft a policy for this.
Thank you so much, sir. So again, you have rightly mentioned, if it's a compulsion in assessment, it will automatically thrive into policy that because the course has to run, accredit itself, one of the criteria, automatically it will be implemented by all residents and the entire department.
Yeah.
Similar way, like Dr. Arnab Bera had mentioned regarding insurance policies. अभी कैसा होता है कि we have to hide, कोई smoker है तो नहीं, उसको pass नहीं होगा, तो corporates में we don't mention smoking. But what if that's just a policy suggestion कि जो smokers है उनका policy का premium ज्यादा होगा पहले से, so they can get reimbursement, but their premium will be more, so automatically that will motivate them to leave smoking that way. So again, we have two audience. I think we'll take one audience question first. Dr. Jayaraman has asked from Tamil Nadu, kindly throw some light on nicotine nasal sprays. So anybody amongst the panelists would like to take this question? Nicotine nasal sprays, any experience, or how do you go about using, if any doctor, anybody amongst the panelists can take this question, please. I think we also have Dr. Ankush,
Ankush is probably left.
Okay, I just saw his name, that's why.
I can mention, I have not such experience, but I have given you a chart, in my presentation, where if the patient actually smokes, within 30 minutes of waking and smokes 10 or, less than a cigarette, you can give a 1 mg spray. So basically, these, nicotine spray are kind of short acting things. Okay, so this is actually combined with a one long acting, maybe a patch or kind of thing, or some medical therapy, pharmacological therapy. And for the short craving part, the short action therapy is for the craving part. You can combine this nicotine spray with with a long term therapy. Okay,
Definitely.
so it's usually available, I think, in 1 mg.
Yes, and I think because of the duration of action, it might help with the immediate dopamine, like the craving effect. We also have a comment from Dr. Lakshmi Murli from Tamil Nadu. It's a comment that I think we had discussed regarding the government TB program. He's mentioned in the NTP, they have a treatment card which mentions tobacco and smoking separately. So if it is filled, they are referred directly to the district tobacco control program, where proper counseling and the behavioral support as well as counseling is done with regards to smoking cessation. So again, coming back to Dr. Arnab, so we've covered smoking cessation extensively. I would request we keep our answers short and to the point so that we can finish on time. Dr. Arnab, coming to rehabilitation, suppose you have to start your patient, this same patient, we've finally been able to address smoking cessation, but still has a lot of breathlessness and cough. So now again, you are the treating pulmonologist. So how do you go about initially assessment for pulmonary rehabilitation as well as outcome assessment afterwards, that whether your program is working or not? And what other parameters do you like? What is your approach in clinical practice with regards to starting a patient on pulmonary rehab?
I do very short, Neil. Basically, I brought this actually. So this is our basically pulmonary rehab program. I don't know it is it is feasible or not. So basically, what we do initially, we have to take a detailed history of the patient. You know, the examination history, the smoking history. Sir has already mentioned. You have to go by your, you know, the MMRC scoring of dyspnea. You can do a 6-minute walk test, the walk distance the patient is covering, PFT value. Usually, you know, as per the goal 2025 or the previous goal guideline also from B and E group, it's pulmonary rehabilitation is recommended. Okay, you can do a ABG for oxygen dependent or patients. Okay, this kind of thing you can do initially. And if your facility is available, apart from BMI, for the nutritional point of view, apart from BMI, fat-free mass index, which is done by a DEXA scan, you can do that part also. And for the quality of life in the part, so we have taken the board index as a quality of life indicator. But definitely there are other questionnaires, you know, St. George respiratory questionnaire, okay, chronic respiratory disease questionnaire, airway questionnaire 20. These kind of things are available in the market. You can choose any one of them. And usually what we are doing, we are very new in our pulmonary rehab program. We are doing for last 1 year in our hospital. So basically what we are doing, we are giving almost 3 months of therapy. And every definitely a visiting round is happening every day with the patients by our registrars or a consultant, whoever is available. And we are keeping a 2-weekly for the severe patient or moderate patients for a monthly follow-up with same PFT kind of things, and the you know, walking distance covered. And to our experience, it's working a lot. Okay, working a lot for our patients.
Thank you so much, sir, for elaborately discussing regarding the pulmonary rehabilitation program. Coming to physiotherapy or physical therapy, Dr. Vrushali. So again, if you are counseling a patient for physiotherapy, so besides what the physiotherapist is going to do, you are going to give them some specific instructions. Considering that we have a lot of young postgraduates as well as other consultants here, as a pulmonologist, do you give any specific advice regarding exercises that a patient supposed to follow in a good rehab program, and how do you integrate this with your chronic COPD or chronic respiratory patients?
So, Neil, I do not keep my rehabilitation for the last. Is the earliest the patient comes to me, whatever stage, when it, you know, class A also for that matter for COPD, we I allude to the concept of pulmonary rehabilitation, which in the regular practice can be just a plain exercise, which is plain walking on level ground, a jog, or something of that kind. Why it is important is that once the patient keeps on moving, automatically the weight gain is not going to be that much. There's not going to be muscle deconditioning, and they are not going to feel further breathless. So this is something which I encourage the patient in terms of, and you guide them in local language, or give a scenario which is like your regular day-to-day scenario. I always so besides your endurance training, which is around 3 to 5 days of walking or a jog, just ask them for a resistance training. We also introduce them to our physiotherapy department. We've been trying to initiate a kind of a 6 to 12 weeks rehab therapy per se in our hospital, which is still in the pipeline, not yet done. But generally, what I've been telling is, just like we tell a tuberculosis patient that your sleep and your food is as equal as your anti-tubercular therapy, so is the part of rehabilitation. And you help them in that once they are moving, generally their mental health stays well. So that is how you can increase their oxygen efficiency. And basically I give them a certain set of exercises myself. So I don't wait for them to go to the physiotherapist. I give them certain sets of exercise myself, help them in the pursed lip breathing kind of a thing, help them in cough clearance or the mucus removal techniques, which will help them breathe free. And this is how I just initiate. And in cases where they require assistance is, so, your higher levels of COPD or who have just been discharged. So the passive movements where the physiotherapist goes home, and if they are able to come to a clinic or even a physiotherapist going home, that is how we initiate based on their levels of symptoms.
Thank you. Thank you so much for elaborately discussing regarding the therapy, physical therapy that we give. And rightly mentioned, we started from the beginning, not when the patient worsens. So again, nutritional support, Dr. Chaithanya, role of nutritional support as well as specific advice that you give COPD, asthma, sleep apnea patients, specifically related to nutrition as part of the Rehab program.
Yeah, I think this is the area where like most of us are lacking knowledge, nutrition therapy, because it's not part of our curriculum. I think Gupta sir, I think we should add even nutrition therapy also in our curriculum and somewhere in the part, because first question whenever asthma or COPD or any patient, like they'll ask what we should eat and what we should not eat. So I think we all should be aware of the nutrition support, and PR doesn't only means physical rehabilitation, right? So it's a comprehensive intervention. So nutrition also comes into part apart from behavioral therapy and everything. We have to initially assess the patient based on their BMI and assess their frailty, assess their how their malnutrition, if they're malnourished or not, whether they're frail or not. We have to assess their BMI. We have to assess their, I was already mentioned, fat-free mass, and then prescribe like a high-quality diet rather than a random diet. This high quality of diet enriched with nutrients is most useful for these patients. It should be done estimated based on their energy needs as such. So it should include 100% of macro and micronutrients, which are essential for like not losing more muscle mass. Should include almost 1 to 1.2 grams of calcium along with vitamin D supplementation, because these people will be on steroids as such. Along with that, other nutrients and food groups, and may require sometimes oral supplementation. And apart from high quality diet, they need also protein rich diet, and protein rich diet, like approximately 1.5 grams of protein per fat free mass is required for these patients. And give also energy restricted diet. Don't give like too much of calorie diet, because like again they'll gain weight, and again that will be a problem for these patients. So energy restricted protein diet is which is really helpful for these patients. So along with some oral nutrition supplementations, always take this, discuss with your dietitian rather than directly referring to dietitian. Discuss with your dietitian and plan the meal for these patients, so that they will be connected to us more than the dietitian. So it will be like, if that comes from our mouth, they'll follow it more than it comes from the dietitian. So have a plan with the dietitian and along with your patient, and go accordingly.
Thank you. Thank you so much for a very precise answer regarding the nutrition aspects of rehabilitation. So coming to Dr. Gupta, sir, again, what is the role of, what do you counsel regarding treatment, specifically educating the patients on self-management with regards to their treatment, what you have prescribed, as well as other integrated care program in case of rehab? We have discussed regarding nutrition, we have discussed regarding physiotherapy, self-management specifically. How do you go about in your practice?
Absolutely, education, self-management with inclusion of the society. It's very useful. Educate the patient by understanding of the disease. What is the disease? If we can understand, we can educate the patient about the severity of the disease. And with the right inhaler techniques, because technique is very, very important for the respiratory patients. Inhaler techniques are very important. And as we all know, oxygen is a drug. So no liberal use of the oxygen, because it may cause toxicity. There are some incidents of the burning. Whenever there is a respiratory distress and patient using high flow of the oxygen and there is a burning, there are chances of the burning. And also educate and promote them about the smoking cessation for this, as well as vaccination. Now, in the coming days after the COVID vaccination, the awareness we should spread about the adult immunization, especially the flu vaccine and the pneumococcal vaccines. These are very, very useful. If the patient is aware and the educated, they will think and vaccinated them themselves, and as well as mental health support.
Thank
So, role of education is very important. To self-education for the ask patient to make the plan, personal plan,
you.
make the personal plan and the goal setting for their self. How many months they can quit the smoking. And we should also approach the society for the integrated system. We also include the local, our colony, our society, and the peer groups for the
Definitely.
integrated approach.
So we, as you mentioned, a self-made action plan in case of an emergency. We teach the
Yes.
patient regarding the inhalers, as well as we involve the local community and the family when we go for self-management. So coming to the next question, Dr. Vrushali. So what are the red flags? So again, this can be taken even by Dr. Arnab or anybody here, that if you're teaching your residents or medical officers when you're going for rounds, and like, when do you feel that these are the red flag signs that this patient, we need to be more aggressive on pulmonary rehabilitation? If you could please, it would help them.
So red flag signs, you mean to, okay, I was taking in two different things. Let's see, one red flag sign is that, these patients having recurrent exacerbations, they're getting hospitalized, or maybe they're coming OPD visits also with recurrent exacerbations. After you have optimized therapy, after you have checked the inhalation technique, after you've ruled out the other confounding variables like a congestive heart failure or an embolism and things like that, then that is the time the PR should be prioritized and it should be aggressively followed. Saying so, also, if a person is on COPD treatment and they are still depressed, anxious, and you feel that most of the other symptoms are because of these, also you can initiate them on a pulmonary rehab. There's another way I look at this question, that there are certain red flags when you won't start the patient on a rehab. So if you have a person who has just been hospitalized, exacerbation has been done, but has a lot of cardiac arrhythmias, he still has an unstable cardiac status, you would not force this person into a rehab. Also, a person who has an oxygen dependent, I always try to assess that after a possible, not a 6 minute, but some amount of ambulation, is the oxygen actually improving or it is worsening? If it's improving, then yes, you go aggressive on the rehab and you can use ambulatory oxygen in the beginning for these individuals. If they are actually deteriorating, then you would like to go a little slow on the rehabilitation or an active rehabilitation. Passive will continue with the help of caregivers and the the physiotherapist. And I think if a person is obtunded and things like that is a place where you really cannot give rehab. So red flags is frequent exacerbation. Despite optimal therapy, the patient has become indrawn. This is the time we should go on aggressive pulmonary rehabilitation. And like Dr. Chaithanya mentioned, even nutrition plays an important part of this rehabilitation. So that protein diet, right from your IPD services, where it can be 1.5 grams per the lean body weight, is what you will initiate and help these patients come out of this exacerbation zone.
Thank you so much for helping us identify the more critical patients needing urgent proper rehabilitation. So madam, you mentioned 6-minute walk test. So Dr. Chaithanya, among the tools, if I would say, you have the COPD assessment questionnaires, you have the MMRC scale, 6-minute walk test. What do you feel is the easiest to implement in your OPDs as well as in your rounds, which can help you and identify among these tools that are available, or any other specific tool that you use in your practice?
Yeah, like we have a very comprehensive pulmonary rehab program at our center. So they are very integrated with our clinicians also. Like whenever the patient goes there, they'll definitely call us back every month. They'll reassess and will be in a part of that journey of the patient. So usually commonly there will be some functional tests and some exercise tests and patient reported questionnaires and the physical activity what we usually go through. So the functional tests are 6-minute walk test and the hand grip test what we usually check, and quadriceps force and endurance time and the Borg scale. So apart in these functional tests, I think 6-minute walk distance and Borg scale, I think we can easily assess at our OPD basis even without any physiotherapist or any rehab program also. And the exercise testing, what we do is a VO2 max, which we need to have a CPAP machine. I think we can skip that in our OPDs. Apart from that, like patient outcome tools. So we'll give them a questionnaire like the chronic respiratory questionnaire, dyspnea respiratory questionnaire, so that they will have an assessment of how things are going from the last month to now and how things are moving forward. Apart from that, like a simple physical activity test like step counting and walking time, like how much they walked before and how much they're walking now at their own pace. Like now all smartwatches contain that number, like how many steps you're walking. So even that, like, so apart in all these, like I think at home and for the patients also to monitor, or for us to tell in the OPD, 6-minute walk distance is the most commonly used thing apart from Borg scale and dyspnea questionnaires and the walk distance walked by them. These are like both documentative, like not only subjective, that all the comprehensive assessment will get with these tests.
Thank you. Thank you so much, ma'am. So, Dr. Arnab, coming back to you. So, specifically, if we talked about a lot of applications, we won't go to that again. But WhatsApp based, so a lot of time you find especially post the COVID era, there is a lot of virtual consultation. A lot of times patient may not want to visit you. However, still you want that the rehab program remains intact. So, any WhatsApp or virtual based platforms or like AI tracking, the madam mentioned watches. So Google Watch, MI Band, these are all routinely now available. Does that help you with rehabilitation specifically in monitoring or in any other way in your practice? Dr. Arnab, I think, yes, please.
Hello.
Yes, yes.
Basically, there is a is and for a very severe COPD, the study by some Gupta is a study, home-based study. So studies they are actually helping for, but I am also.
I think the connection is not clear.
Distant. Hello.
Yes, now you're audible, sir. I think his connection is breaking. So anybody anybody would like to take this regarding use of yes, please, Dr. Gupta, sir, please.
Yeah. Today, as we are using the Google Track system, smart watches, mobile monitoring systems. These are very, very effective in case of the pulmonary rehabilitation, because easily tracking is available from the remote location. It is also available. We can track the values as well as promote and motivate the patients. If a patient walks 10,000 per day steps, so we can motivate them how much is the oxygen level, as Dr. Chaithanya said, 6-minute walk test. So telecommunications and the telemedicine methods today is very useful in today era, through the Google bands and remote watches, sports watches, blood sugar monitoring, BP monitoring, sugar monitoring, and the oxygen and like this. It's very, very useful.
Okay, thank you so much, sir. So the last question before we go to the take-home messages, this one is for Dr. Arnab, Dr. Vrushali can also take it. But basically, we say that in COPD guidelines or the gold guidelines, when we say what is the one, oxygen is one of the things that can impact survival in COPD patients. So when we say that if a patient is oxygen dependent, needing frequent hospitalizations, and in such patients, can we, with a good pulmonary rehab program, in your experience, does it help in reducing the oxygen dependency, or does it help in their survival or their prognosis? What is your opinion, Dr. Arnab?
Yes, I have almost in last year 4 or 5 patients who are actually oxygen dependent when I first see them, and after this successful pulmonary rehab program, I have seen these patients coming to my OPD walking in his own. Okay, so it's possible. It's really possible. The motivation, psychological counseling, nutrition part, and with this, we have two very good respiratory therapists now with our department. They are doing a very great work, and this is possible. I have seen patients. It's working.
So I completely agree with him. Pulmonary rehabilitation definitely gets a patient, in terms of lung function better. In terms of survival, it is much, much better.
During the COVID time, I had also seen so many patients improving with the physiotherapists. During the COVID, I have used a lot.
Definitely,
Fast
sir.
improving is there.
Yes, sir. So thank you so much. We have had a very good and elaborate panel discussion. Before we go to the take-home messages, I think Dr. Ankush has left one message for, he couldn't join right now, but his website is blink.thinkific.com. So that is, he says that fellow colleagues, any residents who need that, that's his website if you want to use. So again, thank you so much for all the more than, I think, around 1,500 to 2,000 audience which was there today for joining us. We'll have one take-home message from each of the panelists. We can start with Dr. Chaithanya, madam. One take-home message from you, please.
Yeah, I think rather than discussing about the hazardous effect of smoking, COPD, and the diseases caused by it, better target the younger generation. So, go into the society and talk with the teens, like college people, where this starts as such. Explain them this so that we'll have that window period of to prevent the long-term complications which we are now dealing with.
Dr. Gupta, sir, one take-home message.
Sir, along with the smoking cessations program and the pulmonary rehabilitation is very, very useful. But as I said earlier, it should be mandatory for each and every resident. It should be a part of the curriculum, as well as to increase awareness about the adult immunization. Yes.
Thank you so much. Dr. Bera, Arnab Bera, sir.
So basically, what I can say, see, lots of things are available with us now, and lots of things we even learn today, but public are not aware. I think we need to do more and more public awareness program, how they can know this kind of apps are available, this kind of programs are available in your hospital. So we should do more and more programs even in remote areas, so that public are aware of these programs, and these apps or these clinics are available in your locality, and they can seek help from them.
So forums like CCI will hopefully help that message go to the doctors and from that to the community. So Dr. Vrushali, one take-home message from your side.
Yeah, and absolutely well point which is mentioned by Dr. Chaithanya is about prevention. We always talk about cessation after that, but prevention. If the government has all its TB control, the tobacco control programs inside, we have vaping which is banned, but we still see kids using and even adults using vaping on and off. We have, in all these, they're playing these videos of smoking cessation and stuff like that. And now with the WHO, the theme for this year's No Tobacco is that, they're making it more flavorful, more colorful. We should find an equally flavorful and colorful way of giving back to the society, and as to the harmful benefits and how you should avoid it. Saying so, also I must mention that our very own Dr. Nitin Abhyankar, who's along with an ENT surgeon from Pune, Dr. Vandana Joshi, they have initiated what is known as prevention of addiction to children's education. So this is the right age where you target the children, make them aware of the hazards of all. They've made short films on nicotine, they've made short films on drugs. So possibly, if all of us could just encourage at the college level, at the school level, that we can go and initiate some kind of dialogue with these children. So, in the rural setup, I remember patients telling me that they started smoking BD at the age of 8. And in the urban, it is usually the age 14, that is, the higher secondary school. If all of us can, just find out, chalk out a program and go to schools, start over there and maybe colleges eventually, that is how we possibly can curtail the beginning of the addiction, because we know that once the patient develops an addiction, it is quite difficult for them to lose it.
Thank you so much, ma'am. So again, as you rightly mentioned, we can use public platforms, colleges to spread this message. And as No Tobacco Day is day after tomorrow, so we know that the tobacco industry is very strong. A lot of times it's even supporting a lot of political people also with the same. That is why it is very strongly still available, and it is marketed very much. So if you see all the actors in the movie industry, they say that bolo zuba kesari. That's what the actors. When a lot of people have asked me as patients that ye to kesar ki ad hai na, this is not the thing is, it does not have tobacco, it is only kesar. So now I think we should make our own campaign that it should be bolo zuban tobacco free or bolo zuban smoking free, something like that. But thank you so much to all the respected panelists for giving your valuable time and again your expert insights and experience today. Thank you, the Chest Council of India, for providing us with this platform. Dr. N.H. Krishna, Dr. Vijay Kumar Chetty, Dr. Anil Maske, and the entire organizing central team of CCI for this platform over the last so many years. And we have just finished exactly on time. So thank you so much to all my panelists. So we could finish on time for this presentation. And I think we have addressed most of the audience queries also. So
thanks to you, Neel, you got out all these questions. And we could answer them. Hopefully most of them.
Yes.
Special
all
appreciation
of them.
to Dr. Neel.
Yeah, it's very, very useful and a very good platform for this virtually connected throughout the country with our good opinions and the very large number of logins.
Yes.
That's the trust of the CCI.
Definitely. Thank you so much. And I think we will finish. We'll conclude right now. Thank you so much. Thank you, everyone.
Thanks.
Thank you.
Bye.